In Chapter 10, we are going to cover the diseases and conditions of the circulatory system. This picture here should look very familiar to you because these are the pictures that we used in anatomy and physiology 2 for when we talked about the gross anatomy of the heart. I'm going to go briefly through the blood circulation and the blood supply to the heart and how it goes out into the lungs and then into the systemic circulation. So blood coming into the heart from levels above the heart, such as the head, enters in via the superior vena cava. Blood entering into the heart from below the level of the heart enters in through the inferior vena cava, which we can't see in this picture here. And the heart actually has its own blood supply through the cardiac veins and great vessels. So once blood enters into the heart, it goes into the atrium. So I'm going to divide the heart into 4 sections here. It actually goes into the right atrium first. And then it passes through the tricuspid valve, and then it goes down into the right ventricle. And then it's going to go out through the pulmonic valve, go through the pulmonic trunk or the pulmonary trunk, and then it's going to become oxygenated out by the lungs. The oxygenated blood supply returns back via the right and the left pulmonary veins, and then enters into the left atrium. Blood then travels down into the left ventricle through the through the bicuspid or the mitral valve, and then it goes out through the aortic valve to the aorta, where it can go out into the systemic circulation. So it can actually go through the brachiocephalic trunk, can actually go through the left common carotid, the left subclavian, and then also throughout to the rest of the body via the aorta itself. So that's just the review of the general blood supply and blood circulation through the heart. So I want you to go through these different structures, just familiarize yourself with them again, because circulation of the blood to the organs and the tissues of the body is the primary function of the circulatory system. They say 1 drop of blood that enters into the superior vena cava, 1 minute later it has circulated through the entire body and will arrive back at that same location. That's a pretty interesting fact. The heart actually beats and pumps about 5 quarts of blood through a complete vascular circuit of the body every minute in the adult. That's known as the cardiac cycle. And the cardiac cycle is responsible for the circulation supply through the network of vessels, which are the arteries, the veins, and the capillaries. So this is just another overview of the circulation. I covered this on the previous slide, so I'm not going to go through and say the exact same thing, but on this picture here, it's nice because you can actually see the inferior vena cava. So again, that's where blood is entering in a deoxygenated fashion from levels below the heart. I want to draw your attention to this side of the screen where we look at the circulation through the body. So this is a schematic of circulation in the body that's showing the head up at the top here. And then where does the blood go? It's going to go to the lungs, the liver, the gut, and then the rest of the body at the bottom. And then there are several labels on this picture, so orient yourself with the right ventricle, the left atrium, and the left ventricle, and just go through this figure 8 circulation of the blood supply. Notice that oxygenated blood is depicted in red and deoxygenated blood is depicted in blue. Blood is actually never blue in the body. This is just a schematic representation. However, if you do look down at the veins on your arm, you may see that they appear blue or appear green. Why is that? Why do you think that is? I'll leave that as a bonus question for the next exam. Explain to me why your veins appear blue. Is it because they're deoxygenated? Has it to do with something else? Does it have to do with your skin color? Does it have to do with light? Those are all some possible answers to the question. Before we dive into the pathologies of the circulatory system, I want you to understand the differences between diastole and systole. So what does it mean when we take systolic and diastolic blood pressures? You may see some blood pressure readings look like this, 120/80 millimeters of mercury. What are we actually measuring? Well, we're measuring the systolic pressure on top and we're measuring the diastolic pressure on the bottom. But what does that really mean? So let's go through this slide and try to better understand the differences between diastole and systole. So what's happening in diastole? Well, first off, the atria are going to fill with blood. So blood is going to enter into the heart via the SVC, the IVC, or the coronary arteries, and the atria are going to fill. And at this point, all the valves are closed. So the atrioventricular valves are all closed here to allow blood to fill in the atria. As that atrial pressure builds, what's going to happen is the atrioventricular valves, the tricuspid and the bicuspid, or the mitral valve, they're going to open to allow blood to flow down into the ventricles. And then we switch gears. Then systole begins. So in systole, the atria are going to contract and they are going to empty out. And the ventricles are still filling with blood. So the ventricles are trying to get to their maximum capacity of blood volume at this point. And then the ventricles are going to begin to contract and pressure is going to close the atrioventricular valve. So we don't want any blood to flow backwards. So that's why we have these semilunar shape to these valves so that blood does not flow backwards. So once the ventricles are completely filled, we don't want any blood going back into the atria. That would be very bad. Next, we go to ventricular contraction. We're still in systole. The ventricles are going to contract and they're going to push blood. They're going to push the deoxygenated blood out into the lungs via the pulmonic trunk, and then they're going to push the oxygenated blood out to the systemic circulation through the aorta. So as the ventricles contract, that increases the pressure. These aortic and pulmonic valves are going to open and allow for blood to be ejected to become oxygenated or to supply the systemic circulation. And then diastole finishes as the ventricles completely empty. Then they begin to relax. The aortic and pulmonic valves close again, and they get ready to, then the heart gets ready to fill again via the atria. Coronary artery disease is a condition in which the arteries that supply the heart muscle, also known as the myocardium, begin to narrow. And they become narrowed because of the accumulation of atherosclerotic deposits or atherosclerotic plaques, and this occurs over time. Eventually, this can lead to more severe conditions such as ischemia and even heart attacks, also known as myocardial infarctions. Initially, the patients may be asymptomatic. They may not even know this is going on. But the first symptom that they're going to complain of is chest pain. The patients can describe the chest pain in many different fashions. They could say that they feel this burning, this squeezing, this crushing pain. They may have pain radiating to the arm, the left arm specifically, the neck, or even the jaw. You may even see nausea and vomiting in some patients. But the way this pathology actually works is because of the atheromas that actually develop, these plaques down here. You can see the plaques start to develop here. As the plaques develop more and more, they start to occlude, and then thrombi can get lodged in the vessels as well. So the vessels can become completely occluded, which could be very, very bad eventually. So the plaques are actually deposits of fat, and the coronary arteries undergo that atherosclerotic process, which, like I said earlier, causes the narrowing of the lumen of the arteries, or the opening of the arteries. And then I want to draw your attention to this picture here. So narrowing of the large arteries by cholesterol plaques and thrombus. What can those actually do? Well, we talked about angina pectoris briefly. This is the crushing chest pain, that crushing substernal chest pain. And that's going to be one of the first things that the patient complains of. As the coronary arteries become more and more occluded and we reach total occlusion, like I mentioned earlier, we can get ischemia, which could potentially lead to further complications and myocardial infarctions. If there are arteries that are clogged in the brain, this could lead to TIA, or transient ischemic attack of the brain. And if that transient ischemic attack isn't treated, and if the patient doesn't change his or her lifestyle, then that can result in a CVA, also known as a stroke, a cerebral vascular accident. In the peripheral arteries, we're going to talk about different types of aneurysms. We're going to see some aneurysms in the aorta, also known as aortic dilatations. So aneurysms can cause occlusion, they can rupture and lead to hemorrhage, and we're going to talk about some of these signs and symptoms that present with hemorrhage. And then we're also going to talk about the peripheral vascular disease if the arteries of the lower extremities become occluded with plaques and thrombi. So initially, changes may or may not be present on EKG. So again, the patient may present asymptomatically, they may present with that initial chest pain, but again, the EKG may be relatively normal. Arteriosclerosis is a little bit different than atherosclerosis. Arteriosclerosis is actually the hardening of the arteries, and this is usually associated with older adults and patients with diabetes. The arteries eventually lose their elasticity and become hard and narrow, which could result in cardiac ischemia. I briefly mentioned angina pectoris on the previous slide, but this is that crushing chest pain, that crushing substernal pain. So this is the pain that's caused by ischemia during or shortly after exertion. And this is the result of a reduced oxygen supply to the myocardium. And sometimes with angina pectoris, patients may have different symptoms. Males tend to report pain going down the left arm. Females tend to report pain that radiates to the back, the upper middle portion of the back specifically. And the patient may also experience dyspnea or difficulty breathing. The pain is usually relieved by stopping the activity, so when the patient rests, that substernal crushing chest pain usually goes away. And also another thing to look at as far as a medical intervention is whether or not the patient is prescribed nitroglycerin. Sublingual nitroglycerin usually relieves the pain, and that will differentiate it from a myocardial infarction, which we're going to talk about on a couple slides. For these patients, lifestyle modifications are immediately necessary. We do not want the patients to progress from just this pain to getting ischemia and eventually getting a myocardial infarction. So as soon as the patients are experiencing these symptoms of angina for the first time, that is a red flag for immediate medical attention. Atherosclerosis usually causes the narrowing of the coronary arteries, which I mentioned already. Again, that compromises the blood flow to the myocardium. And as you exert yourself, that's going to increase blood flow to supply more oxygen to the body. But what happens in angina pectoris is the vessels can't supply that demand. And that results in spasms of the coronary arteries and other etiologic factors that may lead further to ischemia and myocardial infarction. Myocardial infarction is commonly known as a heart attack. You may also see it just represented by the letters MI. So this is the actual death of myocardial tissue that's caused by the development of ischemia. Occlusion of a coronary artery resulting in ischemia and infarct of the myocardium causes this sudden, severe substernal or left-sided chest pain. And again, this chest pain may present different in different people. So you can see here this schematic. Just let me get my marker. Let me change colors. You can see on this schematic here where patients may complain of the pain. And again, it's common in males to have pain radiating down the left arm, very common in females to have pain radiating to the upper back. And again, the pain may be different for each individual. It may be crushing, which may cause this feeling of massive constriction of the chest. It may be burning, or it just might be a minor discomfort. And even sometimes myocardial infarction is clinically silent, especially in patients with diabetes. This usually results from insufficient oxygen supply, which is caused when a coronary artery is occluded by an atherosclerotic plaque, a thrombus, or myocardial muscle spasm. And the pain that the patient is going to be complaining of is usually caused by ischemia. And if the ischemia is not reversed within about 6 hours, the cardiac muscle is going to die. Coronary thrombosis is the most common cause of myocardial infarction. The patient's who experience angina pectoris, they are going to get their pain relieved by sublingual nitroglycerin. Big difference here in myocardial infarctions, the patients who are suffering from a myocardial infarction are not going to have their pain relieved by resting or sublingual nitroglycerin. They might also experience an irregular heartbeat, difficulty breathing, and they may experience a condition known as diaphoresis or extreme sweating. And if you have all this happening to you, it just makes sense that that may be an anxiogenic trigger and may induce anxiety. There are some particular markers that physicians look at when diagnosing myocardial infarctions. The gold standard is going to be the troponin marker. Also, they look at creatine phosphokinase elevation. They look at both of these markers about 6 to 24 hours after the initial MI. Lactate dehydrogenase, or LDH, is also measured 48 hours later, and AST, aspirate aminotransferase, is usually looked at between 48 and 72 hours later. Cardiac arrest is the sudden, unexpected cessation or the stopping of cardiac activity. You may find the patient completely unresponsive, laying on the floor and not breathing, and the pulse may not be palpable. This is a life-threatening emergency. If you're lucky enough to have an automated external defibrillator or an AED around, that should be administered to the patient immediately. If you do not have an AED, start CPR immediately and have somebody else call 911. Cardiac arrest is truly life-threatening. And this usually results from anoxia, which is the absence of oxygen to the tissue. Or it could also be caused by the disruption or interruption of electrical stimuli to the heart. And interestingly, we still don't truly understand how AEDs work. We just know that they trigger the heart to start its electrical signals again. So we're going to talk about how the heart communicates through the nodes via the electrochemical signals in a couple slides. But the majority of cardiac pacemakers are found in the SA node, or the sinoatrial node. And one of the theories behind cardiac arrest is that there's improper signaling. The signal's not going from SA to AV to the bundle of His to the Purkinje fibers, and the signal's just going all out of whack. So what the cardiac defibrillator actually does, it's kind of like the reset button on a Nintendo. Old Nintendos, the screens used to freeze a lot, so really can't fix it other than pressing the reset button. So when the patient gets hit with the AED, it resets the SA node with an attempt to start the electrical signaling to go back to that proper SA to AV to bundle of His to Purkinje fiber signaling mechanism. And again, the most important thing is to get the heart beating again as soon as possible, because this is anoxia. There's no oxygen, there's no blood flowing, and this can result in death if not treated immediately. Hypertensive heart disease is the result of chronically elevated pressure throughout the vascular system. Atherosclerosis, arteriosclerosis, renal disease, and any other condition that creates increased vascular pressure can actually cause the heart to work harder as it has to pump against this new increased resistance. So what should normal blood pressure be? Well, we should have a normal systolic pressure of about 120 and a normal diastolic pressure of about 80 millimeters of mercury. And hypertension could be pathologic. The etiology could be known or unknown. And hypertension is actually characterized by a systolic pressure that is greater than 140 and a diastolic pressure that is greater than 90. So what causes hypertension? People can be born with it, or even stress and elevated cortisol levels can actually cause it here. This can be a condition that you develop over the course of your life. You may experience headaches, epistaxis, which is nosebleeds, lightheadedness, the patient may faint, but usually with hypertension, there are no relative symptoms. The patient may not even know that he or she has it. And this is generally detected just when the patient is getting a normal routine exam at the doctor's office, and the doctor will take the blood pressure as part of the normal screening process and may notice that there is elevated blood pressure. So elevated blood pressure readings are the first indication. You may be in this range between a normal blood pressure. So you may be between 120/80 and this hypertensive state of 140/90. Patients with systolic readings of 120 to 139 and diastolic readings of about 80 to 89 are in a pre-hypertensive state. Not necessarily indicating that they are going to become hypertensive, but they have a higher tendency to become hypertensive. So there are differences between essential hypertension and malignant hypertension. So essential hypertension is basically what I just described. It's the condition where the patients may not even know that they have the condition. But malignant hypertension is a little more severe and serious. This is actually a life-threatening condition. This is a very severe form of hypertension. The patient may present with a headache, blurred vision, difficulty breathing. So again, these are going to be symptomatic malignant hypertension. They're going to be symptomatic, where essential hypertension, they may not present with any symptoms at all right away. So the etiology of both of these conditions is unknown, but this could be due to stress. Stress is thought to be one of the main contributing factors. And again, here on this picture here, there's a whole bunch of different conditions that could lead to the development of hypertension. Congestive heart failure, or CHF, is the acute or chronic inability of the heart to pump enough blood throughout the body to meet the demands of homeostasis. And this is a very, very serious condition. The onset may be insidious, and the patient may eventually experience dyspnea, or difficulty breathing even at rest. The patient may also notice an increase in cardiac and respiratory rates, and this could lead to the patient becoming very anxious. Some of the signs and symptoms that you see here, we have distended neck veins, we see edema, and on the next slide I'm going to explain why we see these things from a physiological standpoint in right-sided heart failure versus left-sided heart failure. So I do need you to be able to differentiate between right-sided heart failure and left-sided heart failure when it results from CHF. So in right-sided heart failure, what we're going to see is we're going to see the abdominal organs start to enlarge. So we get hepatomegaly, or enlargement of the liver due to this congestion, which I'm going to explain the mechanism on the next slide. And then the spleen is also not depicted here, but we get splenomegaly. And when you have enlargement of both the liver and the spleen, we call that hepatosplenomegaly. And another major sign of right-sided heart failure is the edema of the legs and the feet. So the swelling, the stasis of blood down there. Right-sided heart failure is different than left-sided heart failure. In left-sided heart failure, we're going to get increased pulmonary congestion and respiratory difficulties. And I'm going to explain those mechanisms in depth on the next slide. So let's run through this schematic and try to better understand the effects of congestive heart failure and understand why we see what we see with left-sided heart failure versus right-sided heart failure. So let's look at left-sided first. So first off, the left ventricle weakens and it cannot empty. What that leads to is this decreased cardiac output to the system. So the system is not getting as much blood as it should. So remember, from the left side of the heart, we're supplying the rest of the body with that freshly oxygenated blood. And then our body is not getting that due to this decreased cardiac output. And then what happens is the kidneys suffer. So there's a decreased renal blood flow, and this is going to stimulate the RAA system, or the renin-angiotensin-aldosterone system. That causes a lot of different changes in the body, and actually one of the biggest things that happens is there's a backup of blood into the pulmonary vein. So remember, the pulmonary veins are going to be bringing blood towards the heart. This backup is actually putting blood back into the lungs. So what results is this high pressure in the pulmonary capillaries, leading to pulmonary congestion or edema. So that's why you see more respiratory issues with left-sided congestive heart failure. Now let's go down and talk about the right-sided congestive heart failure. So what happens here, let's start with number one, the right ventricle weakens and it cannot empty. So the right ventricle is not able to shoot blood to become oxygenated. Remember, the blood that's entering into the right atrium, the right ventricle, is deoxygenated, and then it has to leave through the pulmonic trunk to become oxygenated via the lungs. So as the ventricles weaken, they can't empty, they can't send the blood for proper oxygenation. And again, we have a decreased cardiac output to the system because this is a very upstream effect where in left-sided congestive heart failure, we already have oxygenated blood and the difficulties on that left side, but this is more upstream with right-sided congestive heart failure. So we're going to get a decreased cardiac output to the system. And again, same thing happening in the kidney. The kidney is going to suffer, and this is going to stimulate the renin-angiotensin-aldosterone system and secretion. And then what happens is there's a backup of blood flow. So instead of going back into the pulmonary veins like we saw in left-sided congestive heart failure, what happens is the blood is getting backed up into the vena cava, either the superior vena cava or the inferior vena cava, which is very, very bad. And then this increased venous pressure results in blood having a higher pressure in the lower extremities. So that's why we get the edema in the legs, and we have the enlargement of the liver and the other abdominal organs. And then this very high venous pressure causes the distended neck vein and cerebral edema. Cor pulmonale is also known as right-sided heart disease, and this is a sequelae of primary lung disease, which results in enlargement of the right ventricle. And again, with right-sided heart failure, the patient may have difficulty breathing. You may see those distended neck veins and peripheral edema. Also the hepatosplenomegaly phenomenon happening. The next condition we're going to talk about is pulmonary edema, which is a condition of fluid shift into the extravascular spaces of the lungs. And this causes patients to experience dyspnea and coughing, and also a new condition that we haven't talked about known as orthopnea. So this is a condition in which breathing becomes easier in the upright, standing, or sitting position. Increased cardiac and respiratory rates and often bloody, frothy sputum are found in pulmonary edema as well. Blood pressure may fall, and you may notice that the skin becomes cold and clammy. You may also see cyanosis, or this bluish discoloration around the lips. You may also even see this in the fingernails. And the symptoms usually occur at night after the patient lies down. A cardiomyopathy is a non-inflammatory disease of the cardiac muscle that results in the enlargement of the myocardium and ventricular dysfunction. These conditions usually cause the patient to have some of the similar symptoms that we talked about with congestive heart failure, which include difficulty breathing, that general fatigue, the elevated heart rate, the irregular heart rate as far as palpitations go, and even chest pain. You may also see that peripheral edema and the hepatic congestion. Fainting, also known as syncope, and cardiac murmurs may also occur. And again, this is going to be different in each patient. There are three specific types of cardiomyopathies. The first one we're going to talk about is the hypertrophic cardiomyopathy. So what actually happens is the ventricles, the muscle of the ventricular walls actually thickens, which causes less space for blood in the left ventricle. So there's a small left ventricular volume and a dilated left atrium occurs. In a dilated cardiomyopathy, what happens is there's dilation of the heart chambers and there's an impaired pumping action. So there's increased volumes of end-diastolic and systolic residual blood in the chambers. So the left ventricle pumping action actually gets weak. The papillary muscles become weak and the trabeculae carinae become weak, so the left ventricle becomes less functional. And in a restrictive cardiomyopathy, this is resulting from the rigidity of the ventricular walls, which alters the filling ability. And this is usually secondary to some type of systemic disease. Pericarditis just means inflammation of the pericardium. And this can be caused by the release of blood or inflammatory exudate in the pericardial sac or the pericardial space. Lots of things can cause pericarditis. Just friction, irritation can cause it. This can be a manifestation of a viral or a bacterial infection, and this is a malignant disease if it is not treated. Patients may experience fever, general fatigue, fluctuating chest pain, and just like we talked about in all the other heart conditions, they may be feeling anxious due to this pounding heart. So pericarditis is usually a consequence of inflammation or infection somewhere else in the body. So like I mentioned, it could be due to a bacteria, could be due to a virus, could be due to rheumatic fever, which we're going to talk about in a couple slides, and the condition may occur secondary to myocardial infarction. Myocarditis is inflammation of the muscular walls of the heart. So similar to pericarditis, but what's actually happened in myocarditis is we're not having inflammation of the pericardium, we're actually having inflammation of the heart muscle. Very similar to pericarditis, the way myocarditis can occur is due to viral, bacterial, fungal, or protozoal infections. And this usually occurs by some type of damage by these pathogenic players or a toxic insult that results. And as these pathogens, the viral, bacterial, fungal, or protozoal pathogens are running rampant in the body, the patient may have an elevated white blood cell count. The immune system's elevated, so all the leukocytes are going to start to respond to kind of try to help out, slow down this pathology. There may be an elevated erythrocyte sedimentation rate, and you may see some elevated cardiac enzymes such as troponin, creatine kinase, things that we've mentioned with the MI. One thing that you will notice with myocarditis is the ventricular enlargement and abnormalities of EKGs. Endocarditis is inflammation of the lining and the valves of the heart. And this is usually secondary to infection elsewhere in the body, just like we've seen with pericarditis and myocarditis. This could also be a result of a pre-existing heart condition or the consequence of just this crazy immunologic reaction that the body's undergoing. The patient may have vague to pronounced symptoms of infection, which include fever, chills, night sweats, weakness, anorexia, as well as fatigue. The most common cause of endocarditis is bacteremia, or the presence of infectious agents in the bloodstream. And the common infecting organisms include Staphylococcus aureus, group A beta hemolytic streptococci, and even E. coli. Rheumatic fever is a systemic inflammatory and autoimmune disease that involves the joints as well as the cardiac tissue. And this usually follows a sore throat that's caused by the group A beta hemolytic streptococci, or Staph aureus. And the patients are usually very young. They're usually children that have a fever and they experience joint pain. Maybe they have a little bit of redness and swelling and even loss of their range of motion. And the joints that are usually affected are the finger, the knee, and the ankle joints. And the patient may also experience carditis, cardiac murmurs, cardiomegaly, and if it's not treated and becomes severe, the patient may even suffer from congestive heart failure. So again, this is preceded by a sore throat that's usually caused by Staph A, and we may get that elevated immune response, that increase in the leukocytes, increase in the white blood cells, because there are antibodies that the body's going to try to develop to fight off the bacteria. And sometimes with this pathology, antibodies against the bacteria that develop, they cross-react with normal tissue. And this autoimmune disease causes the antibodies to attack the body's own cells and initiate this inflammatory reaction. So that's what's actually happening in rheumatic fever. The antibodies then migrate down to the endocardium and the mitral and sometimes even the aortic valves, where vegetations form on the tissue. And then the carditis usually follows the joint pain and a fever by about a week, and it can actually affect all layers of the heart. Good thing about this is the prognosis is relatively good with treatment, and usually the initial diagnosis is going to be that of an upper respiratory tract infection. But there's no single diagnostic feature that identifies this particular condition. Valvular heart disease is an acquired or congenital disorder that can involve any of the four valves of the heart. So it can affect the aortic, the pulmonic, the mitral, or the tricuspid valves. And this condition can form in the form of either insufficiency or stenosis. Let's talk about insufficiency first. Insufficiency is the failure of the valves to close completely, and this is going to allow blood to be forced back into the previous chamber as the heart contracts. So that's the phenomenon that we talked about on the congestive heart failure physiology slide. So right-sided heart failure versus left-sided heart failure, the valves are not closing when they should, and the blood is getting regurgitated back. And what this is doing is that's adding extra pressure on that chamber that it's regurgitating into, and that's actually increasing the heart's workload. And that's all insufficiency. Stenosis, on the other hand, that's the hardening of the cusp of the valves that prevents the complete opening of the valves. And this also impedes the blood flow into the next chamber. The mitral valve is the one that's most often involved. And in order to diagnose valvular heart disease, there are a lot of different tests that the physician's going to have to run. Those include an EKG, chest radiographs, echocardiograms, as well as cardiac catheterization. Arrhythmias are also known as irregular heartbeats. And there are a whole lot of different types of arrhythmias. We're not going to dive into the different classifications in this course, but if you took an advanced pathology course, then you would. But I want you to understand that the arrhythmias are due to this interference with the conduction system of the heart. So throughout the heart, we have specialized cells known as pacemaker cells that work to stimulate the electrical conduction system of the heart. These pacemaker cells are found in the right atrium, the left ventricle, the right ventricle. They're found everywhere. But there is a high amount of them, actually the highest density of them are found in the sinoatrial node, or the SA node. So that's considered the pacemaker of the heart. So signal should go down in this order that's depicted on the slide. I like the organization of this slide because it shows the proper signaling cascade. So signal from the SA node should go to the AV node, or the atrioventricular node. Then it travels down the interventricular septum via the bundle of His, and then goes through the different bundle branches, the right bundle branch, left bundle branch, and then it eventually gets to the Purkinje fibers, which are going to be responsible for stimulating the ventricles, which will eventually make them contract and eject blood. What happens with arrhythmias is that there is some type of disrupted communication. So there may be backwards communication, communication may be skipping steps. There's just some type of erratic communication. We still don't fully understand this phenomenon. And again, this is the whole concept behind the defibrillator. So we want to press the reset button. We want to reset that sinus rhythm. We want to reset the sinoatrial node to go back to that normal signaling, AV, bundle of His, the bundle branches, to the Purkinje fibers. So patients may experience missed beats, palpitations, or even a rapid heart rate and heartbeat. And we think that the primary culprit of arrhythmias is due to the failure of the SA node signaling and firing properly. So again, this slide depicts all of the different types of arrhythmias. I don't expect you to know all these for this course, but I do want to go over what a normal sinus rhythm should be and what sinus tachycardia and sinus bradycardia are. So a normal sinus rhythm, so we should be having about 60 to 100 beats per minute. And we should see a normal PQRST wave on EKG. Sinus tachycardia, tachy means elevated, so this is when that rate goes above 100 beats per minute. Brady means slow, so a sinus bradycardia is when the rate drops below 60 beats per minute. And again, everything listed down here below, these are all the different types of arrhythmias and the conditions that result from arrhythmias. So take a minute, go through them. The main highlights I want you to take away from this slide is understand what a normal sinus rhythm is, 60 to 100 beats per minute, and understand that anything over 100 beats per minute is sinus tachycardia, anything under 60 beats per minute is sinus bradycardia. Shock is the collapse of the cardiovascular system, and this includes vasodilation and a fluid shift, which is accompanied by inefficient cardiac output. And shock results in an inadequate perfusion of organs and tissues. So the patient may become pale, cold, and clammy, and they may have rapid, weak, and a thready pulse with rapid breathing and altered levels of consciousness. And what's going to happen is their blood pressure is going to drop very quickly. The patient may become anxious, irritable, and even restless, and may tell you that they feel like they're going to die. They may feel this impending feeling of doom. They may also experience dizziness, extreme thirst, and profuse sweating. In late stages, the pupils are going to dilate, and then the eyes actually become very dull, and the patient experiences shaking and trembling. So with the decreased blood pressure, these are all the phenomenons that happen. So why do we get this increased thirst is because we are stimulating the sympathetic nervous system. We are stimulating all the excitation aspects. So thirst is going to increase, anxiety, that restlessness is going to increase. We're going to have elevated amounts of our heart, how many times our heart beats per minute, and we're going to get vasoconstriction, which is going to lead to further increase in blood pressure and heart rate. What's going to happen is there's more compensation. So we talked about the activation of the RAA, the renin-angiotensin-aldosterone system. That's going to lead to vasoconstriction, going to tell the body to retain sodium and water. And we're going to also have increased antidiuretic hormone secretion, which is going to help the body retain water as well. So there are other direct effects of decreased blood pressure as well. So the patient we talked about may feel tired, weak, and we may actually shift from aerobic metabolism into anaerobic metabolism. The patient may go into metabolic acidosis, which could lead to all other pathologies and phenomena to happen. Thrombus can form, the thrombus can dislodge and become emboli. Different organs can undergo necrotic events. We get eventually this decreased venous return, and that is going to further decrease our cardiac output, cause the CNS system to become depressed, and then we get decompensation and everything drops off. Shock is something that needs to be immediately attended to because it is a life-threatening condition, so immediate entry into the emergency room. Arteriosclerosis is a group of diseases that are characterized by the hardening of the arteries. And it actually has three forms. So we have atherosclerosis, Myocardial arteriosclerosis, and arteriolosclerosis. So let's start with atherosclerosis. This occurs when plaques of fatty deposits form within the arterial tunica intima. Myocardial arteriosclerosis, medical calcific sclerosis, that's another name for it, involves the arterial tunica media. There's actually destruction of the muscle and elastic fibers along with calcium deposits. And then in arteriolosclerosis, this occurs when the walls of the arterioles thicken, resulting in loss of elasticity and contractility. So with atherosclerosis, this is going to be the condition that's responsible for the most myocardial infarctions as well as cerebral infarctions. So again, this is thickening and hardening of the arteries that occurs when plaques of cholesterol and lipids form in the arterial tunica intima. And that's what we see here. You see this normal lumen, there's no occlusion. Eventually we're going to get this plaque forming here if we have a very bad diet and high levels of high density lipoproteins, the bad type of cholesterol. So if we have an elevation of HDL, that's bad. We don't want high levels of HDL. LDL, low density lipoproteins, and VLDLs, very low density lipoproteins, are the good type of cholesterol. As the arterial atherosclerotic disease progresses, more and more of the lumen becomes occluded. And then as you can imagine, thrombi and emboli can get lodged in here, further occluding the artery, which could lead to myocardial infarctions. Preceding the MI, usually angina pectoris, dizziness, elevated blood pressure, and shortness of breath. An aneurysm is the weakening and local dilation of the wall of an artery. And the symptoms really depend on the location and the size of the aneurysm and the extent of the dilation. the abdominal aortic aneurysm is the most common form. And it may present asymptomatically, and physicians may just kind of discover this on a physical exam, a routine physical exam, when they are palpating the abdomen or they're doing a chest x-ray for some other reason. But as the aneurysm enlarges, the patient may experience abdominal or back pain. They may also feel their heart beating in their stomach. So that's that pulsating mass that they may develop or may be able to observe in the abdomen. And a complication of any aneurysm is leakage from the wall of the artery or sudden rupture of the weak area. And when this occurs, the patient exhibits symptoms and signs of hemorrhagic shock. Signs of a rupture of a cerebral aneurysm mimic those of a cerebral vascular accident or a stroke. Varicose veins are swollen, tortuous, and knotted veins that usually occur in the lower extremities. And the symptoms of varicose veins, they take a while to develop. They develop gradually. And one of the first things that the patient will complain of is this feeling of fatigue in the legs, which is followed by a continuous dull, achy pain. And they may also say that they're having leg cramps, and the leg cramps may be worse at nighttime. But as the condition progresses, the veins are going to thicken and they're going to feel very hard to the touch. And the pain is going to worsen. And that pain can change from that dull feeling into a stabbing or pins and needles quality. So varicose veins, we don't really know why they happen, but they are thought to be due to defective or absent valves. So remember, veins allow for blood to travel back up to the heart. Veins have an anti-gravity feature because of the valves, so they can pump blood against gravity. And when those valves become defective, then the blood can remain stagnant and get occluded in these lower extremities. So normal movement of the legs causes the muscles to contract and relax, thus milking the blood upward. But when a person stands or sits for extended periods of time, what gravity is actually doing is it's pushing blood downward with resulting pressure on the valves. And without the normal muscular contractions, the venous walls distend, and they reach a point at which the valves are no longer competent. So again, that blood is going to pool in the lower extremity. Raynaud disease is a vasospastic condition of the fingers, hands, or feet. I call this the American flag pathology because you see red, white, and blue in the area that it's affecting. So this disease can cause pain, numbness, and even sometimes discoloration, that red, white, and blue phenomenon. So the white phenomenon, we see pallor, we can see the cyanotic or that blue discoloration due to the weakened blood flow, and we may even see erythema or reddening of the areas here. And it waxes and it wanes. It changes from all different colors over time. So the fingers become white due to that lack of blood flow, then they're blue as the vessels dilate to attempt to keep the blood in the tissues, and then finally they turn red when they are being rapidly perfused again. So what's actually happened in Raynaud's phenomenon or Raynaud's disease is the small peripheral arteries and arterioles supplying the area go into a spasm and constrict. And this does compromise the overall circulation. The episode usually resolves spontaneously after the application of warmth. So Raynaud disease and Raynaud phenomenon tends to occur when the patient's in a cold environment. And this is a condition that is usually made worse by smoking tobacco and drinking alcohol. And now for the anemias. There are a whole bunch of different types of anemias, but as a whole, they are conditions of reduction of quantity of red blood cells or hemoglobin in a particular amount of blood. So if we don't have hemoglobin or if we don't have proper red blood cells, well, then our body's not going to get the oxygen that it needs. And with all the anemias, we see relatively the same phenomenon. We see pallor, the whitening, we see the fatigue, the dizziness, the shortness of breath, and irregular heartbeats. So don't need you to necessarily be able to differentiate between the different types, but I listed all the different types down here: iron and folic acid deficiency, pernicious anemia, aplastic anemia, sickle cell anemia, which we've heard of, I'm sure, hemorrhagic, and hemolytic. So the anemias are classified based on the size of the red blood cells or the size of the erythrocytes. So It could be normocytic, so if we have that really nice biconcave disc shape, the anemia can be a normocytic anemia. It could be microcytic if the red blood cell is smaller than normal, and it could be classified as macrocytic if it's larger than normal. And this is an example here of a patient who is suffering from sickle cell anemia. So what actually happens is the cells sickle, and over time they lose their hemoglobin binding capacity, which would result in a decrease of oxygen transport to the body. And as they sickle, they actually become more sticky and they tend to agglutinate. So they can actually clog up different vessels and lead to other issues with oxygen transport and cause other symptoms to happen in the patient. And finally, for the leukemias. So the leukemias are a group of blood disorders that are usually indicated by an increase in leukocyte amount. And they're all different types of leukemias. And again, this is just a subclassification of some of the leukemias that are known. But I do want you to be able to differentiate between ALL, CLL, AML, and CML. I like to reorder these. I like to put ALL as number 1 because I like to order these in terms of the chronological age group that it affects. I like to put CLL as the last chart, or the last column in the chart. I like to put AML as number 3 and CML as number 2. And the reason I do that is because I always remember this mnemonic AC current. So AC. So we have acute lymphocytic, we have chronic lymphocytic, we have acute myelogenous, and then chronic myelogenous leukemia. And this order is the order of the demographic that the leukemias tend to affect. So ALL, I always remember this little mnemonic, all my children. This is usually seen in very young children, ages 3 to 7. CLL is usually seen in really old adults. And again, these leukemias can occur in any age group at any time, but chronic lymphocytic leukemia usually occurs in the oldest population, and this also has the worst prognosis of all the leukemias. CML, chronic myelogenous leukemia, it tends to occur in adults, but it can occur anywhere from children all the way up to adults. And then AML, acute myelogenous leukemia. So let's differentiate between these conditions. So I may give you an elevated white blood cell count. That's going to be indicative of a leukemia. If you see a child in the clinical vignette, definitely pick ALL. And children with Down syndrome tend to have a high incidence of ALL. Children with Down syndrome also tend to have a high incidence of developing neurodegenerative diseases such as Alzheimer's disease. And because it occurs very early on in children, it's usually detected very early and it has a really good survival rate. Let's move over to CML now. So I'm over here. So in CML, what happens here, we know that there's a translocation of the Philadelphia chromosome. So you're going to see that in the clinical vignette. And it's usually occurring due to some previous radiation exposure. So I may give you a patient who has worked in a biomedical laboratory who was exposed to radiation every day. An older patient, there's a translocation of the Philadelphia chromosome, and I need you to pick chronic myelogenous leukemia. Acute myelogenous leukemia, very similar exposure. Could be due to radiation, but also benzene and other alkylating agents. These are usually some of the agents that cause AML to occur. And there's the age range usually 45 to 80 that occurs here. And then finally, CLL. So CLL, chronic lymphocytic leukemia, that's going to be the worst prognosis. It's predominantly only in adults. I think it's 100% in adults. I think that is an accurate statement to make. Very poor cytogenics, so very poor prognosis. Usually when you're diagnosed with CLL, you have between 4 and 10 years. This down here, it says 10 to 14. Different books will say different things. My poor pathophysiology book will say 4 to 10. This is from the Goodman's Pathology, the Pathophysiology for Physical Therapists. This says 10 to 14. So CLL. So take some time, and I want you to find some other interesting facts about the leukemias that differentiate them from each other. So again, I'm going to give you a clinical vignette. ALL is going to be the young child, CLL is going to be the old adult, and then CML and AML are going to be the ones in between. Remember the Philadelphia chromosome for CML, and remember the benzene and alkylating agents for AML.